Mr. Chairman, ladies and gentlemen, dear colleagues, it's my distinct pleasure to discuss with you the evaluation of prescribing with NOACs versus vitamin K antagonists in non-valvular AF patients. These are my disclosures. Well, you have heard already that we have now the NOACs available worldwide, and over the last 5 years, 4 non-vitamin K antagonist oral anticoagulants have received regulatory approval as alternatives to standard of care, which has been so far vitamin K antagonists. First, dabigatran came into the market or was approved by FDA in 2010, followed by the 10A inhibitors shown on the right side from November 11 until January 2015. So, this you have already seen again, but I can't resist showing it one more time, that Garfield data show an increase in the prescribing of anticoagulant therapy over time, and as you can clearly see, there is the increase over time, but also then the relative percentage to NOACs, the prescribing of VKAs has diminished since 2010. That is a fact worldwide, and we can't shake that anymore. Between March 2010 and July this year, the NOAC prescribing has risen from a median of 4% to 64% among the anticoagulated patients. That is the picture over time shown here. And by April 2013, that means when the cohort 3 was up and running, NOAC therapy was theoretically available in most countries. Of course, we need to keep in mind that when a new compound comes into the market, that it's not fully reimbursed from the first day on, but I think from cohort 3 onwards, which was in 2013, at least they were available worldwide. And with this outset in mind, I would like to say what we did as an analysis. We evaluated the trends in NOAC versus VKA prescribing therapy from April 2013, as already mentioned, up to now, August this year. And this includes data from cohort 3 to 5. We had now 34,000 patients available, 34,127, and out of these, 23,690 were anticoagulated with or without adjunct antiplatelet therapy. And out of these anticoagulated patients, 12,050 patients received the novel oral anticoagulants, and 11,640 patients received vitamin K antagonists, again taken together, patients with and without additional antiplatelet therapies. And you can also easily see that meanwhile, worldwide, we have a confirmed statement that the NOACs have slightly surpassed the vitamin K antagonists, which had been standard of care so far. So the first analysis of the relationship was between all variables and NOAC versus VKA use. And this included the countries, care settings, and patient characteristics. And you can easily see on the left side of this graph that in particular the countries and kidney disease had the highest relative significance for prescribing either or vitamin K antagonists or novel oral anticoagulants. If we drop the countries now from the model and focus on care setting and patient characteristics, you may see in the following slide that the care setting, location, and also specialty here have the highest relative significance in saying or in determining which patient may receive one or the other type of anticoagulant, that means novel or anticoagulants or vitamin K antagonists. So this was with only information on the patient and the care settings, because the countries were dropped from the model. And if we now focus exclusively on the care setting location, you can see that the patients treated by investigators who were based in the hospital setting or in the hospital setting the patients had a higher chance to be treated with vitamin K antagonists, which is shown here when compared to the investigators who worked in the office or in the anticoagulation clinics, that means outpatient care setting. So hospital and also emergency room setting has the same pattern. If the patients were treated here and were compared then in the model against the outpatient setting, office or anticoagulation clinic, again there was a higher chance to receive standard of care instead of a novel or anticoagulant. What's about the specialty of the investigators? That's shown here. We have also primary care physicians and colleagues who come from the field of geriatrics, and if we compare this group against the group of cardiologists, again, the patients have a higher chance to be treated with standard of care. The cardiologists obviously are using more the novel or anticoagulants. Same is true for the internal medicine when compared to cardiology. Again, the patients have a higher chance to receive vitamin K antagonists. Only the neurologists have moved it to the right side a little bit, but that was not statistically significant. So that is an interesting finding, because worldwide we have so different care settings, and so there is the chance where you are treated to predict which type of treatment you may get worldwide. So with the only information now about the patients included, the most important factors in deciding treatment are age, adjunct antiplatelet therapies, type of AF, and kidney disease, which is shown here. Main focus on patient characteristics, and that is driven by adjunct antiplatelet therapy, type of AF, and kidney disease, and that is then also shown later on in more detail. Here we have just a summary listed by the order of relative significance, listing all factors which were associated with the prescribing pattern. And for me as a clinician, it was interesting to see that history of systemic embolism obviously was associated or is associated with the prescribing pattern, but history of systemic embolism, but history of stroke is not. I hadn't expected that. So we have perhaps an explanation for that, because history of systemic embolism is clearly ischemic, but history of stroke can be both ischemic or hemorrhagic stroke. That perhaps gives us a clinical answer why history of stroke may not be associated as a significant factor to predict prescribing. This graph clearly demonstrates which patient characteristics are associated with either NOAC or vitamin K prescribing. Again, AF type is playing a major role. Age is playing a role. The elderly patients have a higher chance to get vitamin K antagonist prescribing. Females higher chance to receive novel or anticoagulant treatment. Antiplatelet therapies as adjunct therapies, these patients have a higher chance to get vitamin K antagonists as standard of care, and other factors, in particular kidney disease, is popping out here. These patients are predominantly prescribed with standard of care and not with novel or anticoagulants. So we can conclude and say the variability in NOAC relative to standard of care prescribing is primarily due to differences in availability of treatment worldwide and prescribing habits between countries and care settings. Furthermore, the clinical factors associated with NOAC prescribing are the type of atrial fibrillation, in particular paroxysmal and persistent, dementia and history of bleeding, and also female gender in favor of NOACs. And clinical factors associated with VKA prescribing are permanent AF, kidney disease, antiplatelet therapy as adjunct therapy on top of anticoagulation therapy, diabetes, and history of systemic embolism. So I would like to conclude and say, even though NOACs have demonstrated efficacy and safety compared with VKA in challenging patients, many physicians are still reluctant to prescribe them. This is in spite of data from the randomized clinical trials showing that these are good choice for these patients, and I think we still need to work in clinical practice to change treatment patterns. Thank you very much for listening.